Morning, one and all. The subject is psychiatry. The topic will be obsessive compulsive disorder and its management. My name is Dr. Agila. I'm assistant professor from the Department of Psychiatry, Sri Lakshminarayana Institute of Medical Science, Puducherry, Bharat Institute of Higher Education and Research, Chennai. The topic is obsessive compulsive disorder and its management. We'll be seeing about what is obsessive compulsive disorder, its etiology, its diagnostic criteria, its assessment, its management, that is investigation and treatment. So we'll be going one by one now. So what is OCD? It's an anxiety disorder. The person has recurring thoughts. That is, it could be either thoughts or images or repetitive thoughts, or it is ritualistic type of behavior that individual is unable to keep from doing. That is, the obsession is a thought and a compulsion is usually a behavior, but there are also mental compulsions. The person may try to suppress these, but it is very difficult because usually these are uncontrollable and these are irrational, and person feels very much powerless to stop it. So DSM-5 describes OCD as recurrent obsessions or compulsions that are severe enough to be time-consuming or to cause marked distress or significant impairment. So it is like very difficult to control these impulses. These are recurrent thoughts. So now we are going to epidemiology of OCD, 2.5% lifetime prevalence. Prevalence is similar for men and women. Onset occurs typically during adolescence or early adulthood. Onset is earlier in males than females. Tends to be chronic without treatment with periods of waxing and waning of symptoms. This is one of the toughest for and challenging for any psychiatrist. So obsessions are intrusive, distressing thoughts and mental images which repeat over and over. They are ego dystonic, experienced as unpleasant. Common obsessions are: we have dirt and contamination, we have pathological doubt, need for symmetry, hoarding, sexual content, that is blasphemous religious thoughts, aggressive contents, and superstitious fears. So what are the compulsions? They've been denoted as unwanted repetitive behavior patterns or mental acts. Like I said, compulsions are usually behavior or it is mental act that are intended to reduce anxiety, not to provide pleasure or gratification. So these are the common obsessions if you see. Number one stands contamination. This was in a sample of 200. Like contamination, almost 45%. Pathological doubt, 42. And somatic, 36. Symmetry, 31. Aggressive, 28. Sexual, 26. Others, 13. And multiple obsessions, 60. So usually this multiple obsessions, we get a lot of patients with multiple obsessions, like sexual thoughts, that is blasphemous thoughts. Then we have scrupulosity, like many other like pathological doubt, contamination. So many together we usually get in our OPD. So the compulsions, if you see, the most common is against checking. They usually tend to check the door again and again, like while sleeping, they wake up in the middle of the night, they go check, like this. It keeps on going like a cycle for almost like 20 to 30 times over the period of night. And washing and cleaning is 50%, which is very common. Now this can be confused with OCPD, who are generally personality, obsessive compulsive personality disorder, who also have this tendency. So it needs to be thoroughly evaluated, like before calling the person OCD, that is obsessive compulsive disorder. Counting, 36, need to ask and confess, 31, symmetry precision, 28%. Coding, 18, multiple compulsions 48. Again, like I said, this multiple obsession, multiple compulsions are the most common among OCD. Now, if we go to the etiology, we have biological, psychological, and social. So, biological, we always have the serotonin hypothesis, brain imaging, genetics, and neuroimmunology. And in etiology of psychological etiology, we have psychodynamic theory, personality theory, behavioral theory. And in social, we have accommodation and adaptive mechanisms. So, this is a classification ICD-10. F42 will be OCD, F42 will be predominantly obsessive thoughts or ruminations, F42.1 will be predominantly compulsive acts, F42.2 will be mixed obsessional thoughts and act, F42.8 other obsessive compulsive disorder, F42.9 obsessive compulsive disorder, unspecified basically. So etiological factors, we have the psychoanalytic theory. That is, OCD patients have weak and underdeveloped ego. Now, this we can correlate to the psychoanalytical theory. We have another etiology called psychosexual theory. Now, we'll go on to that later, but here it is like unsatisfactory parent-child relationship, or it's a conditional love. Usually, parents' love is unconditional, but here it is very much conditional love. These could be the reasons for underdevelopment of ego, which usually happens from 0 to 18 months. Now we have psychoanalytic theory continuity, that is regression to the pre-Oedipal anal sadistic phase. That is, I was talking about the psychosexual theory, where there is arrest at the anal stage. That is, it starts from 18 to 36 months, or 18 to almost 18 months to 3 years of life. That there is anal phase in which there is usually toilet control, and usually there is toilet training, all these things going on, and usually a strict mother or a mother who's doubting if the child has washed properly, or there are too much of like pressure on the child. So the child is prone to develop obsession in the late stage. That is, usually they tend to go into OCPD rather than OCD. Later on, they may develop OCD. So this is one particular theory from Sigmund Freud, where he has said there is regression to the pre-Oedipal anal sadistic phase. That is, anal sadism is usually expelling the feces in a very aggressive way, and so this anal sadistic and anal hedonistic. Hedonistic will be holding the feces, that is to gain pleasure, and anal sadism will be expelling them in a very aggressive way. So combined with the use of specific ego defense mechanism, usually there is an isolation, undoing, displacement, reaction formation. Now, if we go into this, isolation is there is one particular isolated thought usually. That is, it could be doubt, it could be any disgust, it could be related to emotions that can in the later stage develop into an entire obsession. Then there is undoing. Now, undoing will be responsible for the compulsion. Now, when there is obsession, there is anxiety. To relieve the anxiety, we do some compulsive behavior. Now, this undoing is correlating to compulsive behavior. And then there is displacement and reaction formation. Displacement, again, here it is usually displaced. Here it is not that much of significant reaction formation and displacement. Mostly it goes into phobia mechanism. So, pathology of phobia. So these are mainly isolation and doing. So learning theory, here we have it is a conditioned response to a traumatic event. Here we have the conditioning, like we have classic conditioning, open conditioning. Here we have it is a conditioned response to a traumatic event. So usually This traumatic event produces anxiety and discomfort. That is passive avoidance, staying away from the source. Active avoidance, staying with the source. So these are the two types in learning theory. And then we have biological aspects, that is on neuroanatomy, neuroimaging techniques, where we have found out that there is higher metabolic or abnormal metabolic rates in basal ganglia and vital or frontal cortex of the individuals with OCD. Then we have biochemical factors, that is the neurotransmitters, serotonin. Like serotonin is the neurotransmitter for OCD as an influential etiology of OCD. Then we have selective serotonin reuptake inhibitors, through which we were able to correlate that serotonin has a big role in OCD. So it is basically uh, serotonin. Serotonin is very low. So this is causing a big mismatch and balance in the loops in the brain. That is, we have orbitofrontal cortex pathways, then we have the cingulate gyrus from which there are projections to the frontal cortex, then we have the CSTC loop, that is the corticostriatothalamic thalamocortical loop. Now we have the diagnostic criteria, that is anxiety disorder with presence of obsessions or compulsions, ego dystonic. It's usually now the biggest difference between OCD and OCPD is that ego dystonicity and ego syntonicity. So ego OCPD are ego syntonic and OCD are ego dystonic, which means it is not in synchronization with the ego. That is, they know that the thoughts are irrational and are excessive and are unwanted, basically. So it must take up at least 1 hour a day, must disrupt a daily routine. Symptoms can't result from effects of other medical conditions or substance. Now, this is the diagnostic criteria which is given. That is diagnostic guidelines and specifies from OCD, of OCD from ICD-10. So for definite diagnosis, obsessional symptoms or compulsive act or both must be present on most days for at least 2 successive weeks and be a source of distress or interference with activities. The obsessional symptoms are as follows. Now they must recognize as the individual's own thoughts or impulses. They must be recognized. There must be at least one thought or act that is still resisted unsuccessfully, even though others may be present, which the sufferer no longer resists. The thought of carrying out the act must not itself be pleasurable. The thought, images, or impulses must be unpleasantly repetitive. Like I said, it is usually recurrent. It is recognized as their own thoughts and impulses. It is usually unsuccessfully resisted. Like they try to resist it, but it is unsuccessfully resisted. Then we have usually the unpleasurable sensation from the thought. And if it is definitely repetitive, then it is OCD. So that is obsession. So it is usually a thought, image, or an impulse. So these are the basic things. Again, specify as we've already seen. Now, symptoms of obsession, like we have already seen, repeated thoughts about contamination may lead to fear of shaking hands. They may not even shake hands. They may not even touch any object. If they touch, and during this corona period, like we have this severe obsession even among normal individuals where they keep on sanitizing, they keep on washing their hands, and that fear of catching corona. So this thing is like even common these days, even more so these days because of the pandemic going on, and repeated doubts. That is, this is like we discussed, it is very, very disturbing for the individual. Then the symmetry, actually this is symmetry. Like when the pencil is just, you can see the picture, you just put it a little bit skewed or deviated from the normal direction, then the person will feel like a little bit anxiety. So this is like a very common among OCPDs. That is, you can see people who are always keeping their books in perfect lining and without any, being crooked or inclined or just lying on the shelf, not like that. It should be straight and perfect and aligned with all the books, and it should be in height order. So this can be a part of OCPD as well. So there's thoughts of aggression, example, to hurt a loved one. Like they get sudden thoughts that the husband or the father, someone is meeting with an accident, or if they take a knife, then they'll just look at the knife and they'll get the thought of just hitting them with a knife or just cutting them with a knife. And sexual imagery, and then there is blasphemy. Sexual imagery, again, it can be with anything, like it can be just an image where two people are just having intercourse, or it can be just like a image with even idols, that is deity. So that is curiosity. So here we have the different types, like how they have too much of symmetry, and this you can see there is the first, there is too much of hoarding. So the first image is like she has just kept everything together, like and sometimes they say OCD people, they tend to be clean on the outside, but they're actually dirty on the inside, which means it's not like inside, as if inside the house you can see their room. It may be very dirty. So here we have washing, cleaning. These are the compulsive acts. Here we have the washing, cleaning, and counting. Then there is checking. Then requesting or demanding assurances from others. Yes. Now you can see how orderly they've arranged, like colors. This is extreme. Uh, uh, like you can see. This may not be extreme. This can be common with even normal people, but it's very typical of OCD. So these are the clinical features: obsessional thought, obsessional rumination, doubts, impulses, rituals, and slowness. And here are the assessment techniques. We have anxiety disorder interview scale, ADIS-R, Yale's Brown Obsessive Compulsive Symptom Checklist. YBOC is the most widely used. We have used in almost all the patients of OCD. Latent obsessional inventory also we have used, and STATE, that is state a trait anxiety inventory of children. Now, diagnosis, they've seen that MRI and CT shows enlarged basal ganglia in some patients. PET scanning shows increased glucose metabolism of basal ganglia. So here we can see that is obsessive compulsive disorder. You can see the hyperperfusion, that is high energy use in the brain in the typical person with OCD. Now, OCD found excessive with other diseases, that is depression, schizophrenia. Depression is the most common, like 2/3 suffer from depression, and people with OCD common diagnosed as schizophrenic. Hard to separate obsessions from delusions. Now, that is a very big discussion by itself. It's called schizo-obsessive. Now, that is very clear basically, schizo-obsessive. Now, it's not like very hard to differentiate obsessions with poor prognosis, that is obsessions with absent insight, or delusional um, prognosis. Like they have like a very strong belief that this is true, even though they know that will be like a three-stage. That will be first one, definitely they know it is not true. Then it will be like may or may not be true. Then delusional, they'll go into delusion. Now that is where it gets difficult. Otherwise, we can still diagnose OCD from schizophrenia very easily, because OCD is clearly neurotic, schizophrenia is clearly psychotic. We have a terminology called schizoobsessive. Now, in that case, it is very clear that the patient generally started with schizophrenia, and then the picture shifted to OCD. So it is quite easy, but this happens only when there is delusional insight. Like the person feels that uh, if there is some thought, for example, he's having intercourse with the god, now he will think it is true. Like he will not try to deny it, or he will not try to oppose the thought. So these are the differential diagnoses, that is anxiety disorder, substance induced anxiety, BDD, trichotillomania, NDD, and generalized anxiety, hypochondriasis, specific phobia, delusion disorder, and psychosis in illness. And in children, it's associated with learning disorder and disruptive, that is disruptive, intermittent disruptive behavior disorders, intermittent explosive, that is also tic disorders. And in adults, it's usually MDD, phobia, social phobia, panic disorder. These are comorbidities, like it's associated with GAD, eating disorder, personality disorders, avoidant personality disorder, and dependent personality disorder. Now, treatment, there are four types, that is pharmacotherapy, cognitive behavior therapy, psychosurgery, and deep brain stimulation. Now, pharmacotherapy, if you see, SSRIs are the first line drugs, that is higher dose than for MDD, that is 80 mg fluoxetine, 10 to 12 weeks before switching. Clomipramine, first FDA approved, more serotonin specific for PCC. Actually, clomipramine and fluoxetine definitely are the first line we always start with. Now, augmentation can be done with lithium or atypical antipsychotics, like when there is delusional insight. So our first choice will be SSRI, that is fluoxetine, but in children it will be sertraline, 25 to 50 mg. Then we have MAOIs. We don't use these nowadays, but it was used to treat. But now we are not using these. And psychotherapy is now the first and foremost we usually start before even pharmacotherapy is CBT. Like we start with that. If it is a mild form, definitely CBT is going to work wonders, and we have had success with CBT. So CBT, we have it is randomized control trial supported, longer lasting than pills. Cognitive, that is challenge the faulty reasoning. Okay, and example magical thinking, behavior, exposure, response prevention. Now CBT, it should be done when people are ready for it. That is, they must be customized. It must be customized for each and every person. Now, when I had patients, I had different set of individuals, like different individuals with different complaints. Like I cannot just keep a formula, ready-made formula, and say this is a behavior therapy for those. No, it's not like that. Now you have to see how much of cognition is involved and how much of behavior is involved. Now, depending on these, everything in cognitive behavior therapy may change. That is, the cognitive restructuring may change, and behavioral part also may change. Now, if cognitive restructuring is needed, then definitely there might be a need of pharmacotherapy to help. Now, if it is only the behavioral part, then definitely it's just behavior therapy that can do wonders for the patient without pharmacotherapy. Now, this is my personal experience and my own success story. So I always feel like if it is only involving the behavior, that is only involving compulsion, and the person is very much aware of the obsession, that it is definitely not true, and they are able to control it, they are able to deviate. Definitely, with behavior therapy alone, that is without any medications, we can help them. But still, if they are requesting that this needs to be stopped and this needs immediate intervention, then definitely we can go for pharmacotherapy. But usually these CBTs are extremely successful, provided it's done in a proper way and it is planned at least for 12 weeks. Now, I plan it usually at least for 12 weeks, or we plan it usually up to 6 months. So, positive effects of CBT last longer, because now it is like you're correcting the entire cognition, and you're going to make changes in the loops of the pathways, those are interconnected. So if OCD returns, can successfully treat again with the same therapy. So that is how it is important, CBT. Now, exposure response prevention, from the name, you expose the person, you get a response, and then you prevent it. Now, there are two components here, exposure treatment and response prevention treatment. Now, treatment starts with exposure to situations that can cause the least anxiety. Like for example, now they see dirt and they get disgusted. Now you just show little bit of dirt, that is some dirty place, and then we go on to the dirtiest place like a garbage or a street side garbage. Like it is very it's like sort of graded only. As the patient overcomes these, we move on to situation that cause, so it is like a graded exposure. And then exposure response is controlled exposure to objects that situate or situation that trigger obsession while raising anxiety. So it is like direct or imagined. It can be direct also, like asking just imagining them to touch the wash basin and open the tap and then not washing hands. Like how much obsession that can trigger. So over time the exposure leads to less anxiety, and over a longer period it leads to a very little anxiety at all. So that's why the period of 12 weeks minimum. Now we are going to do it over a period of time. Now we are going to desensitize the patient. Now, this is the concept of ERP. Now response prevention is ritualistic behaviors that people with OCD engage into. So patient learn to resist the compulse to perform rituals. Like for example, you see a patient or you touch a patient and you need not use a sanitizer. Okay, you have to in pandemic times, but other times, okay, so you need not. Okay, at once for all, you can just wash your hands. That is okay. Not like OCD patients where they have to, okay, if they're doctors, where they will keep on washing for each and every patient, each and every touch. So it is very difficult. So this is how we can ask them to resist. Now we have OCD locks for people who have checking behavior at night. Now we have these locks which are like press them and then you lock. Once you lock it, only you can take the key out. Now we have this OCD lock in many places available. Like you can even suggest for your friends and relatives if anyone has got this checking behavior. Now once the key is with them, definitely they have locked the door. So they need not worry, they need not get up in the night. So this is an excellent way of response prevention. That is, you give them the full assurance that the lock cannot lock itself without the key being removed. So the key has to be removed for the lock to be locked. Common difficulties during ERP is again the first and foremost difficulty we face is 6 months we will not be able to catch hold of the patient, and continued passive avoidance. Now they keep avoiding. Now, whenever you go, active avoidance is a very good process in OCD behavior therapy, but they keep on doing passive because they never just get exposed to the stimulus. And arguing about ERP requirements, emotional overload, like family reactions. And emotional overload is something which is like very common. Like there might be excessive anxiety and there might be excessive distress, and maybe patient may go into depression because they are asked to do certain things. And here we have the CSTC loop. Now this is what we are talking about. The deep brain stimulation disrupts action of CT. This is CT is hyperactive. Basically, corticothalamic root is hyperactive. If you can see this cortex to thalamus, this connection is being disrupted, and this is for DBS actually. Now here we have OFC and then to striatum, and then this is a negative feedback to striatum to thalamus, and this will be a positive feedback either ways. Okay, so DBS targets this region. Now you can see like I mentioned earlier, it's O for olfactory orbitofrontal cortex, then we have prefrontal cortex, then we have anterior cingulate gyrus, and we have the limbic system. So, and here we have the affective loop. This is the emotional loop. Okay. So electrode is placed in the anterior limbofrontal capsule. Modulation of OFC, ACC, striatum, thalamus, and globus pallidus activation. Now this is in very resistant case. Like people are still doing it, but it is a more severe case. Now, treatment refractory psychosurgery, basically now we don't follow this, but there are still people doing it who have failed medication and therapy. Response rate is only 50%. Now, it's actually cingulotomy, subchordate tractotomy, limbic leucotomy, capsulotomy, interrupt signals from OFC to basal ganglia, gamma knife, that is the anterior lumbar internal capsule. Now, here we can see the so improvement here, if we see. Now, there is no improvement, partial improvement, a good response. First is SSRI, that is fluoxetine. Second SSRI is sertraline and clomipramine. Then we have no. If it is no, then switch over to the next step. Then there is partial, then we can add an augmenting agent. Then if it is good response, continue same dose. Similarly, second SSRI, we have the same. Now, for clomipramine, if there is no or partial response, add behavior therapy, continue the same dose. Combination of clomipramine and SSRI and novel approach, and PMS and neurosurgery are for the last. Now, prognosis 20 to 30% significant improvement, 40 to 50% moderate improvement, remaining 20 to 40% stay ill or get worse. So this is the rule of thirds. It is chronic waxing and waning, like I said. Now, poor prognosis factors, that is ill rather than resisting compulsions, childhood onset, bizarre compulsions, need for hospitalization, coexistence with depression, delusional beliefs or overvalued ideas, and coexistence with personality disorders. So, good prognosis is good social and occupational adjustment, presence of precipitating events, and episodic nature of the events. These are the good prognostics. So, PANDAS is something which I wanted to mention. That is first noticed as behavioral problem accompanying Sydenham's chorea in rheumatic fever. Immune response to GAPs, that is glutamate beta hemolytic streptococci, with cross reactivity to basal ganglia antigen. Now, basal ganglia have some molecular mimicry antigens. Now, that is why this is happening as a it's like a PANDA, like a pediatric autoimmune neuropsychiatric disorders associated with streptococcus. Now, we know rheumatic fever, it's also the same concept of molecular mimicry, but here we have PANDAS in which basal ganglia. Okay, basal ganglia antigen has a molecular mimicry and cross reactivity. So no clear immune markers are there. Intravenous immunoglobulin, penicillin prophylaxis have been tried for children. Now this is OCD experience. A man who washes his hands 100 times. A woman failing to wash her hand this is not OCD. Woman locks and relocks every half an hour. Here it is double checks. Even this we do. Okay, we do this. A college student who must tap on the door frame every classroom 14 times before entering. A musician who practices. Now, this is quite understandable, right? Like a musician practicing. It is like, obviously, anybody who wants to, like even we do that. A woman who stores 19 years of newspaper just in case there's no system for filing or retrieving. A woman who dedicates all her spare time and money to rebuilding her record collection. Now, this we can do, this organizing even we can do. Now, OCPD, like I mentioned, it's a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency. Now, this is ego symptomic. Like I said, it is very much in synchrony with the ego. There is preoccupation with details, rules, and lists, perfectionism that interferes with task completion, excessively devoted to work so that leisure activities and friendships suffer. Yeah. So, like we have ego, OCD is ego dystonic, OCPD is ego symptomic. OCPD lacks true obsessions or compulsions. Like I said, OCD patients are found in clinic while OCPD go to medical school. Yeah. Thank you. These are the references.